Hello everyone. Welcome to the second session for MRCOG Part 2. I am Dr. Devyani, your mentor for just MRCOG. Let's begin with the recalls on recurrent pregnancy loss. Okay, so here we will be referring to the Green Top Guideline number 17, which has been recently updated in 2023. We will also look into the TOG article, and you also have the ESHRE guidelines on recurrent pregnancy loss, but these will be more helpful in the EPCOG exams. For the MRCOG, we will be referring to the Green Top Guidelines specifically. All right. So coming to your question number 1, a 30-year-old lady has history of 3 recurrent miscarriages. What is the important investigation to be done here in this case now? So you have the 5 options. Put in your answers in the chat box and we shall see the answer. Okay, so here the answer is antiphospholipid antibodies. Look into the Green Top Guidelines, which says women with recurrent miscarriages should be offered testing for acquired thrombophilia, particularly for the lupus anticoagulant and anticardiolipin antibodies prior to pregnancy. All right, you also have this table which says antiphospholipid antibodies have to be tested, specifically the lupus anticoagulant and the anticardiolipin antibody. All right, moving on. What percentage of women with recurrent miscarriages have antiphospholipid antibodies, right? So how many percentages of women will show that they have APLA positive? That is seen in about 15% of women, okay? Antiphospholipid antibodies are present in 15% of women with recurrent miscarriages, okay? And women who are having a low risk obstetric history, only 2% women will have APLA antibody positive, okay? And read the last sentence here. In women with recurrent miscarriage, associated with APLA antibodies, the live birth rate with no intervention is only 10%, and hence 90% there can be a risk of fetal loss and treatment has to be started. That is, we know aspirin and low molecular weight heparin has to be given. All right, moving on. A patient presented with history of 3 miscarriages. The anticardiolipin antibodies was found to be raised on initial investigation. When should the test be repeated? So now this patient is already having one episode of raised anticardiolipin antibody, which has been seen on the testing. Now you have to repeat this test after a period of about 12 weeks to us to confirm, because there can be a false positive result and that has to be ruled out. So 12 weeks, that is 3 months, is our answer in this case. Yes. So 3 months. To diagnose antiphospholipid syndrome, it is mandatory that the woman has 2 positive tests at least 12 weeks apart for either of the antibodies, that is either lupus anticoagulant or anticardiolipin antibody of immunoglobulin G or M class present in medium to high titer, okay? That is 40 to 90. And it should be more than 99th percentile, more than 40 gram per liter or ml per liter. All right? Okay, so the fourth question now. What percentage of first trimester miscarriages are due to chromosomal abnormalities? We know chromosomal abnormalities is the most common cause. And what is the percentage? Let's see the percent. It is 50%. Okay, so look at the highlighted part. Approximately 50% of sporadic miscarriages are a result of fetal chromosomal abnormalities or anomalies. Okay, moving on to the next question. Women with history of 3 miscarriages has come at 6 weeks of gestation now. Previously, she was tested positive for TPO antibodies. When should her thyroid function test be done? Now during the pregnancy. So what is the gestational age? It is about 7 to 9 weeks. Let's look at the reference also. 7 to 9 weeks of pregnancy. Regular TSH measurement from 7 to 9 weeks of gestation is recommended in case with patients who are having TPO antibodies positive or who have subclinical hypothyroidism. Okay, moving on. Women with history of 3 miscarriages at 6 weeks of pregnancy presented to the A&E with bleeding. What advice would you give her? Now, if a patient with 3 miscarriages presents with bleeding, what is the recommendation? Yes. Yes, correct. The answer is 400 milligrams of micronized vaginal progesterone would be given. This would be given twice daily when she presents with bleeding and given up to 16 weeks of gestation. So answer is C. Okay. Progesterone supplementation should be considered in women with recurrent miscarriage who present with bleeding in early pregnancy, and the dose is 400 milligrams of micronized vaginal progesterone twice daily at the time of bleeding until 16 weeks of gestation. All right. Now moving on to the next question. A 32-year-old woman presents with a history of recurrent miscarriage. The anti-cardiolipin antibodies in her initial visit were high. What will be your advice? So we've seen this when you have one incidence of positive antibodies, you repeat it after a period of 12 weeks, and then you decide if she is a case of confirmed APLA syndrome or not, right? So the answer here would be A, repeat test after 12 weeks. To diagnose antiphospholipid syndrome, it is mandatory that the woman has two positive tests at 12 weeks, and this should be 12 weeks apart for either the lupus anticoagulant or anticardiolipin antibodies. We've read this recently. Okay. Coming on to the next question now. Which of the following is least consistent association with miscarriage? You have all the 5 options. All these options are your inherited thrombophilias, and you have to choose which one is the least consistent association with miscarriage. Okay, for this you must know all the tables which are there in the Green Top guidelines. Then only you can answer this. Okay. So the answer is protein C deficiency. Let's read what the Green Top guideline says. Factor V Leiden mutation is associated with first as well as second trimester miscarriages. Okay, you can see here. Prothrombin gene mutation is associated with recurrent miscarriage. Protein S deficiency, you can see it has demonstrated a association with second trimester but not with first trimester. So you can remember S for S, protein S is associated with second trimester miscarriages, but not demonstrated a consistent association with a first trimester recurrent miscarriage. Now coming on to protein C deficiency, it has not shown a consistent association with recurrent miscarriage. Okay, so your answer is protein C. Let's also see the other points. Methyl tetrahydrofolate reductase has also shown a significant association with recurrent miscarriage. All right. And this is another question which can be asked, that is, which is the most thrombogenic mutation? That is antithrombin deficiency. It is the most thrombogenic mutation. All right. Let's move to the next question. Women has a miscarriage at 18 weeks. Now, this is a second trimester miscarriage. Okay, just look into it very carefully if it is a first or a second trimester miscarriage, right? So, a woman has miscarriage at 18 weeks for the first time. She is upset and wants to go for further investigations. What is the correct advice you would give her? Now, would you recommend a genetic testing in this or not? So this is a second trimester miscarriage. Let's see what the answer is. You accept her request and arrange for genetic testing. Okay. So cytogenetic analysis should be offered to any pregnant women and on the pregnancy tissue if she presents with third and subsequent miscarriage, that is in the first trimester, or any second trimester miscarriage. So if she's presenting even with the first incidence of second trimester miscarriage, you will offer her the genetic testing. All right. Okay, so what is the success rate of subsequent pregnancies after 3 consecutive miscarriages? So if she presents again with pregnancy, what is the success rate? It is about 75%. So the reassurance is very important in such women, because even after 3 consecutive miscarriages, the success rate of the 4th pregnancy would be 3 by 4, that is 75%. Okay, so read into the highlighted part here. Prognosis for a successful future pregnancy with supportive care alone is in the region of 75%. So only supportive care in dedicated miscarriage clinics, dedicated the recurrent miscarriages clinic, will be helpful in carrying out a successful pregnancy in these women. Okay. So which of the following uterine anomaly is most commonly associated with recurrent miscarriage? We all know septate uterus, bicornuate uterus, both are associated with increased risk of recurrent miscarriage, but the highest risk is seen with septate. Okay, let's see what the answer is. So septate uterus, you can read here, women with septate and bicornuate uterus have a significantly increased risk of first trimester miscarriages. Now here you can see the number as well, the relative risk, the ratio for first trimester and second trimester as well in septate is more than bicornuate, that is 2.65 and 2.95. In bicornuate, you can see it is about 2.52 and 2.9. All right. Okay. Coming on to the next question now. How many weeks after third miscarriage can a woman go for APLA testing? So now this question is different from the previous one. We know that 2 tests have to be done 12 weeks apart. But when should the first test be done after a miscarriage? That is the question. And the answer is 6 weeks. So to diagnose Aplar syndrome, it is recommended that women should have two positive tests at least 12 weeks apart, and this has to be done at least 6 weeks post miscarriage. All right, moving on to the next question. How many weeks after a second trimester miscarriage should a woman be advised inherited thrombophilia screening? So the APLA screening, as we saw in the previous question, was done 6 weeks after. The same thing goes for a second trimester miscarriage. Yes, you are correct. So second trimester miscarriage, after that, you will wait for 6 weeks and then you go for inherited thrombophilia screening. So testing may be offered with second trimester miscarriage for factor V Leiden mutation, prothrombin gene mutation, and protein S deficiency 6 weeks after the miscarriage, that is 6 weeks postpartum, and also in the absence of hormonal medications. All right. Okay. Coming to the next question now. A patient presents with history of 4 recurrent miscarriage, and she has a 16-year-old from a previous marriage. What is your next step? Yes, so here we definitely know now that the patient has a healthy child from a previous marriage. Therefore, now in this marriage, the partner has to be tested first. So the partner karyotyping will be done. All right. Yes, so the answer is A, partner karyotyping. So moving on to the next question now. Which of the following is the greatest determinant of recurrent miscarriage? Yes, this is an easy one. Yes, that is right. So the answer is C, maternal age. Overall, the greatest determinant of incidence of recurrent miscarriage is age, right? So the age, maternal age, more than paternal age is implicated in recurrent miscarriages. So yeah, this is the last question. Recurrent miscarriage with structural anomalies. What is the first line investigation? So if you're suspecting structural anomalies, to diagnose it, a 3D ultrasound, especially a transvaginal ultrasound, is indicated. So the answer is B, 3D USG. Okay. Women with recurrent miscarriage should be offered assessment for congenital uterine anomalies, ideally with a 3D ultrasound. All right. Okay, so these are very important tables from the VNTAP guidelines. Just let's go through it, and you have to keep on revising them so that it gets into your mind and you are thorough with these. Okay. So first one is the epidemiological factors. You can see that advanced maternal age is having increased risk along with paternal age as well, but not as much as maternal age. Then the number of previous miscarriages, black ethnic background, smoking, excessive alcohol, excess caffeine, BMI less than 19 or more than 25, all these are associated with increased risk of recurrent miscarriages. Now, some factors like previous live births, consanguineous relationship are having no association and no increased risk. And some factors have some limited research and needs more further investigation. That is chemical exposure and dietary intake is one such of them. Okay. Let's see the next tables now. Here, the acquired thrombophilias, as we know, in the patients presenting with recurrent miscarriages, you have to offer them testing for APLA antibodies, especially the lupus anticoagulant and anticardiolipin antibodies. Regarding the inherited thrombophilias, there is a weak association, so you do not routinely offer them. If she is presenting with a second trimester miscarriage, then inherited thrombophilia testing can be offered. Right now, if there is parental chromosome rearrangement, then there is increased risk of miscarriages as well. And as we saw, that chromosomal abnormality is the most common cause of miscarriages, that is 50%. All right. And then if the miscarriage is of euploid pregnancy, there is again an increased risk of subsequent miscarriages. All right. Moving on. Now, as we saw already, congenital uterine anomalies like septate and bicornuate uterus have an increased risk of miscarriage, but the association with acquired uterine anomalies has not been established. Studies are limited. So you should remember that the congenital uterine anomalies, especially the septate, and then second is bicornuate, are implicated in the recurrent miscarriages. Cervical insufficiency, again, we know cervical incompetence is a risk factor for increasing the risk of second trimester miscarriages. All right. Coming to the endocrine factors now. As you can see the highlighted part, subclinical hypothyroidism, thyroid autoantibodies, polycystic ovarian syndrome, and prolactin imbalances. All these are having an increased risk, but well-controlled diabetes, well-controlled thyroid disease, and luteal phase defect, these have no association or they have insufficient studies. right? Now coming to the immune factors, peripheral immune factors, again insufficient or inconclusive evidence. Uterine NK cells, that is the natural killer cells, these also have insufficient evidence, and genital tract infections also have insufficient evidence. So all these are not having any implication, or the studies are limited, so we cannot say that these factors cause recurrent miscarriages. Okay, so peripheral immune factors, uterine NK cells, and genital tract infections are not associated, right? Coming on to the male factors now, increased sperm DNA fragmentation has shown an increased risk of recurrent miscarriages. Acquired thrombophilias, we saw already, they are associated with increased risk of miscarriages, and hence APLA testing has to be done in these females, right? Inherited thrombophilias, if she's presenting, a female is presenting with second trimester miscarriage, then you may offer her testing for factor V Leiden mutation, prothrombin gene mutation, and protein S deficiency as well. But first trimester miscarriages are not associated with inherited thrombophilias. All right. Okay. Now, genetic factors again. So, you know that cytogenetic analysis has to be done in third and subsequent pregnancies in case of first trimester miscarriage. But if she's presenting with even the first incidence of second trimester miscarriage, you have to offer her genetic testing for the products of conception, right? Now, parental peripheral blood karyotyping should be done if you see that there is some abnormality in the products of conception, that is unbalanced structural chromosomal abnormalities there, then parental peripheral karyotyping has to be done. But in case the products of conception, the pregnancy tissue is not available for testing, then you can directly go for the parental peripheral karyotyping. And also, if the tissue of pregnancy tissue shows that there is some abnormality in it, then again the next step would be parental peripheral karyotyping. All right. Right. So coming to the anatomical defects now, if you know, if you feel, if you see that there is any evidence of congenital uterine anomalies, you have to diagnose it with your 3D ultrasound. It is 3D transvaginal ultrasound scan, right? Now the endocrine factors again, thyroid function test assessment has to be done. That is TPO antibodies need to be done in patients who are presenting with recurrent miscarriages. That these have to be offered to them, the TPO antibodies. All right. Again, the immune factors we saw, they are not associated, and so the immune factor testing should not be routinely offered to the patients who are presenting with recurrent miscarriages. Infections again not associated, so the women with recurrent miscarriages should not be routinely offered any infection screening. Male factors now again, these couples with recurrent miscarriage should not be routinely offered sperm DNA testing. Okay, routine offering is not done. Now, coming to the lifestyle modifications, we saw the BMI, it should be between 19 to 25, less than 19, more than 25 are at increased risk of miscarriages. Smoking has to be stopped. Limiting alcohol consumption has to be done. Coffee, that is caffeine intake, also has to be reduced. It should be less than 200 milligrams per day. All right. Now coming to the thrombophilias, acquired and inherited thrombophilias, we know that the acquired thrombophilias are associated with recurrent miscarriages. So if a female is diagnosed with APLA syndrome, she has to be started with aspirin and heparin. Aspirin is about 75 milligrams per day. Okay, it is to be given orally, and 40 milligrams subcutaneously heparin, that is enoxaparin, is to be given since the UPT, that is the pregnancy test, becomes positive, and has to be given up to 34 weeks of gestation. All right, but this aspirin and heparin should not be given in women who have unexplained recurrent pregnancy losses. So only in women who are having diagnosed this diagnosed case of APLA syndrome, they have to be started on aspirin and heparin. Okay, now coming to the inherited thrombophilias. So inherited thrombophilias, there is a lack of evidence to support the routine treatment for women with factor V, all these inherited thrombophilias. So testing in cases has to be done only if the female is presenting with second trimester miscarriages. Okay, and the decision for giving them treatment has to be individualized. Okay, now coming to the genetic factors, options for couples with chromosomal rearrangements include attempting for doing a PGT, SR or gamete donation. Okay, but there is insufficient data to support the routine use of PGT-A for couples with unexplained recurrent miscarriages. So this is very important regarding the genetic factors. Now coming to the anatomical factors, congenital uterine anomalies, we know that they are associated with recurrent miscarriages. So resection of a uterine septum should be considered, right? But in cases of acquired uterine anomalies, there is a lack of evidence, and so any further treatment is not recommended, right? Now the immune factors again, immunotherapy is not to be done, not recommended again for women with recurrent miscarriages. So what does it include? The paternal cell immunization, third party donor leukocytes, trophoblast membranes, and intravenous immunoglobulins. All this is not recommended in patients who are having recurrent miscarriages because the association is weak or no association is seen. Right? Now coming to the endocrine factors, thyroxine supplementation is not routinely recommended in patients who are euthyroid. Okay, even if they have TPO antibodies, but if they're euthyroid with a history of miscarriage, thyroxine supplementation is not routinely recommended. Right? Now, thyroxine supplementation may be considered in women who have subclinical hypothyroidism, that is TSH is more than 4. But if the TSH is more than 2.5 and less than 4, then you don't recommend thyroxine supplementation. All right. And when should the testing be done? We have already seen it is from 7 to 9 weeks of gestation in the pregnancy if they had a previously TPO antibody positive. All right. Now, progesterone supplementation we saw is to be given, that is to be given 400 milligrams, and that micronized progesterone has to be given twice a day when she starts bleeding up to 16 weeks of gestation. All right. Routine supplementation of progesterone is not to be given, or it has to be given with caution in asymptomatic women. So only if they present with bleeding will you start them on vaginal progesterone, that is micronized progesterone. Okay. Now, again, the male factors, there is no evidence to recommend treatment for the male factors. We saw this already. Endometrial scratching is also not recommended in patients who are presenting with recurrent miscarriages. Coming to psychological support here, it should be offered to every woman who is presenting with the recurrent miscarriages, ideally in a setting of a dedicated recurrent miscarriage clinic. All right. Now coming to the management of subsequent miscarriages. So even for subsequent pregnancies, they have to be offered supportive care in terms of communication with the healthcare professionals, ultrasound examination, and access to services in case of subsequent miscarriages. Why? Because we know that 75% of the women will have successful subsequent pregnancies just with the help of supportive care. Okay, so these are all the important tables from the Green Top guidelines for the recurrent pregnancy loss. Uh, I think this is all. Yes, thank you very much for joining in. And I hope you revise these tables again because they are really very important for you. And definitely questions will be asked and they are being asked again and again. Thank you so much.